Hello everyone, I'm Rachel Lowe from Physiopedia. I'm back here today talking to Dr. Christian Barton. Hi Christian.
Hi Rachel.
We have just completed 4 weeks of the knee course. We met Christian in week one and we had a chat to Christian in week one. We've been learning from the resources and all the people that we've spoken to on this knee course over the past 4 weeks, and there have been some really interesting messages coming out. I think there's been some key messages that have come across. For instance, patient education and communication is one of the key messages that I've been hearing, and another one has been load management, allowing people to reduce their load and enable them to do appropriate exercise therapy. So I think those are the two of the key messages I've been hearing. But Christian, I was wondering if we could finish off this course talking to you today about some of your key messages for people, for physiotherapists who are managing individuals with knee pain.
Yeah, sure. So firstly, thanks to those guys who filled out the survey as well that I put out. I think the vast majority did. And I'll send out a follow-up survey around that, along with some other resources to hopefully fill in some of the gaps for people. Interesting you said the key message coming out around education and load management, because I jotted down a top 10 things to do for knee, and the number one is to educate your patients about the importance of load management. And I think that's really important. So too much too soon is the most common reason that people develop knee pain in the first place. And that can be from the standpoint that they may be very active already and playing sports or running, and then suddenly they have an event that they train up for and they maybe don't give themselves enough time. So they might go from 10 kilometers to trying to train for a marathon and doing that really quickly. Or it's people who are maybe a bit more sedentary and they go on a holiday to Europe and they walk a whole heap of stairs and do a lot of extra walking, and suddenly they've got knee pain, or maybe they're just even more sedentary through that and sitting on the couch and they decide to get up and try and lose weight. So that's the most common reason people develop knee pain in the first place. We obviously have some trauma on occasions, but that's less common. And then it's also thinking about educating patients about load management, not just for their recreational activity, but also their rehab as well, and us thinking really carefully about that side of things. So most of the times that rehab goes wrong is us probably prescribing too much too soon. So we're going to need to be really careful about that. And I think it's about finding the load tolerance of the knee in that individual and trying to get to that point and then gradually increasing that. And I think that's probably the key thing. If you get that right, you're going to go a long way to getting your patients better.
So can I interrupt slightly? How do you find that load tolerance point?
Yeah, I think it's probably there's a little bit of art in what we do in some ways as clinicians, but I think you need to talk to them about what have they been doing recently, and it might be that they've suddenly increased the amount of exercise they're doing, or maybe they're moving house or whatever it might be. So if we can find something that's aggravated them and talk to them, and hopefully it's a one-off thing that's happened, and in that case we can educate them and get away from those things and maybe reduce their loads, and we might just start at an arbitrary figure of, well, okay, let's halve how much running you're doing, or halve how much walking you're doing. And if we can find a point where they're at that happy level where they're not too irritated, and the way I tend to monitor this is if you go for a run or you go for a walk or do some form of exercise today, 24 hours later, tomorrow, what's your pain like? Now, you might have chronic pain that's always persistent and just slightly there. If that's no worse tomorrow, so 24 hours later, then we can be pretty confident that we haven't gone too far in terms of how much exercise we're doing. Now, if you halve your exercise and you're still getting those flares 24 hours later, then maybe you need to back it off a little bit more. But if it goes well, then we gradually build up from there. And there's this age-old rule of 10%, and it's probably not a bad one to follow if you're unsure about how much to do. So that tends to be how I kind of monitor things along the way.
Useful.
Yeah. The second thing is, I think what we need to be really careful of, I think it's probably come across very clearly in the course, that exercise is outside of education is probably our number one intervention, especially as physiotherapists. But we need to think really carefully about our prescription and what we're trying to address. So it's not so much just assessing what the knee pathology is, because that can be important, but actually what's often more important is, well, what are the deficits of that individual that's reducing their ability to tolerate load? So are there soft tissue mobility or joint mobility issues that maybe we can target through some exercise? Are there neuromotor issues? So maybe they've got poor activation through their gluteal muscles and hip, or maybe poor activation through their core. And I know I was listening into Lee's discussion about VMO and how we become very obsessed with that for a number of years, and I think that's a really important point. But it might be that there is an imbalance in quadriceps muscle function, but it's not so much about timing and making sure this little muscle works, but maybe when we're contracting our quadriceps, it's more of our lateral quads than our medial quads, and we can do simple things like rotating to external rotation when we do some quadriceps exercises. So by external rotation, I mean the hip, and that can target our medial quads a little bit more. Or moving on from that, are we more focused on strength at this point of their rehabilitation? So does someone have okay neuromotor control and mobility, but they're just really weak, and in which case we need to prescribe exercise for weakness? And I think a lot of physios fall into the trap of just giving the same exercises to the same patients all the time, when really it needs to be individualized depending on what their deficits are. And then if we move on to point 3 that I've jotted down, it's probably key thing is educate the patients about why you're prescribing the exercises. So it's no good me just giving an exercise to a patient to increase their hip strength. When they look at me and they go, hang on, Christian, I come to you for a sore knee. What are you giving me these hip exercises for? My hip's not sore. But they need to have a really good understanding about how the hip mechanics might link to the knee. We know the hip is going to control half of your knee joint. So it's very clear to us as physios, but not always so clear to the patient. So we need to educate them about that. And if we're giving them more neuromotor type exercises, why are we doing them? And we need to educate them that, okay, this might be a little bit frustrating to work on and we might not load it up a lot straight away, but they're quick and we're not going to do them for a long period of time. It's only going to be for a couple of weeks. And then we're going to progress on to the strength and the more exciting part of it. So I think the patient needs to have a really good understanding about where those exercises fit into their rehab and recovery, and why they're dedicating a good chunk of their life to doing them. Because if we don't educate them on that, then our compliance is going to be really, really poor. And if we continue around, I guess, exercise prescription, it's not just what we're trying to achieve with the exercises, but also understanding the principles of exercise prescription. So I think one thing that physios often do really, really well is we're really skillful at prescribing exercises, and we give exercise and we teach them really well. But sometimes we get the prescription principles wrong. And even myself, it's not something that I learn a lot of in undergraduate. And it's something I've sort of had to learn along the way. And by exercise progression, we need to think about load. So how heavy the exercise is. And this comes back to the first point about load management. So we don't want to give a patient too heavy a load of an exercise that they can't tolerate at the beginning. But equally, we don't want to leave it at the same load all the way through. We need to progressively increase that load as we go along. So we may need to eventually get them in the gym or something like that. And part of that progression is the resistance and the load. And also one of the other key variables is thinking about the time under tension of the muscle. So the common thing that physios will do, well, here's 3 sets of 10 exercises, let's go and do this. And a lot of patients will do 10 repetitions of an exercise very, very quickly. But we know that physiological adaptations there are going to be quite poor. Now, that might be okay in the early stages because they may not have very much muscular endurance, so they may only be able to do 20 seconds of an exercise. But if we want to get good adaptations, we need to make sure that exercise goes for a longer period of time. So thinking about that. And that's also about thinking about aerobic exercise. So, for example, walking tolerance may be really poor in someone at the beginning because they're not able to take that much load, but maybe they can walk 5 minutes and they don't have too much pain. And then if we be really sensible at a progression, we can build their cardiovascular fitness, being mindful of the knee tolerance over time, and it might be adding 1 minute every few days. You add 2 minutes a week, starting at 5 minutes. If you go 10 weeks down the track, you're going to have 25 minutes of walking all of a sudden, and that's a really good time frame to be able to be worked through. And add another couple of weeks and you're at your 30 minutes a day. So thinking about those progression principles, I think is really, really important.
So how do you say a lot of physios do like three sets of 10 or something.
Yeah.
How do we choose where to start then?
Yeah, so I think the way I normally prescribe my exercises in my clinic is rather than focusing on repetitions, I'll tend to focus on time. And what I'm looking for is the patient can do that exercise with good quality for an absolute minimum of 30 seconds, but ideally I'd like to see 45 seconds. And then what I do is make sure they can work up towards doing it for a minute. And the reason I choose those timeframes is that's based on resistance training principles that we know from, at least from a healthy population anyway, that will lead to physiological changes. So if they can't do the exercise for 30 seconds, then we need to make the exercise a bit easier. So maybe we reduce the load or make it a little bit easier. So you might be giving, let's say we're talking about the hip and doing exercise to strengthen the hip, and we try a single leg bridge. and they can't get good motor control of their hip, and they're not feeling their gluteal muscles. They're feeling a lot of hamstring or a lot of back on a single leg. So maybe at the beginning we start on 2 legs, and then we build up the strength that way, and then we progress towards 1 leg with partial support from the other leg, and then we progress towards 1 leg. So I think if you use that guide about 30 to 60 seconds, and then generally what we're aiming for is around maybe 3 repetitions. So the literature in resistance training tells us that somewhere between 2 and 4 minutes of time under tension is probably going to lead you to physiological adaptations of the muscle. So if you kind of focus it around that, I think that's a key thing to work on.
And they need to be able to do it for the exercise for that period of time in good form. So so you're looking really until failure or failure of form.
Yeah, exactly. So if they're not failing by a minute, then the exercise has probably become too easy, and we probably need to make it a little bit harder. But if they're failing before 30 seconds, then it's probably a little bit too hard. And you can be adaptive with that too, because you might find, if we use the bridge for an example, you might find they can do that single leg bridge really, really well on 1 leg for 20 seconds, and then they start to fail. So that doesn't mean you might not do that on 1 leg, because they might be a runner. They might need that sort of strength. But we might do 20 seconds on 1 leg, and then we transition and we do another 40 seconds on 2 legs, so that we can really try and work the muscle. And I think that's the key thing. Yeah, and I think you need to be really adaptable to, so it probably brings me to the next point, which you need to be adaptable to, able to change your exercise prescription as well, because you're not going to get it right the first time every time. It's not always going to happen. You do the exercise prescription and you go through it with the patient. You teach them, you think they've got a good grasp of it, and hopefully they do. But they come back and they say, oh, I've been doing those exercises, but knee's getting really sore. And it's getting worse. And 24 hours after I do my exercise program, my knee's much worse. So you need to be able to adapt those exercises and have a few tools in your toolbox in terms of what you do, and know how to regress it. So go back, I'll just keep using the bridge for an example. You might have prescribed that double leg bridge and they're going through full range because they couldn't do single. But then they come back and they say, oh, by the end of it, my quadriceps are really sore and my knee's sore, and it's sore for a few hours after doing that. Well, maybe you adapt it and you just go halfway up. So you only do half bridge. So just working along those lines. And I think that's really important. I think one of the things about that adaptation is I see this a lot, because I see a lot of really chronic bad patients who have had some pain for a long time, and you talk to them about their exercise prescription, and a really common one I see is people get prescribed single leg squats a lot, which I always find interesting. And a lot of times they don't have the hip control to be able to do it. So if you've got really good hip control, great. Single leg squat can be a great exercise, but a lot of the basis for prescribing an exercise like that is based on people who don't have pain. And we look at EMG studies and it shows that we get really good gluteal muscle activation in someone who doesn't have any pain. But when you actually do this in someone who's got pain, then the gluteal muscle function is usually impaired. And therefore, when they do something like a single leg squat, well, actually they don't get good gluteal muscle function. Their hip control is poor and it'll often irritate them. So being really sensible about that. So we might try that, and the point being you need to regress back and think about other things, and maybe we do some hip exercises that don't irritate the knee, and then we work towards something like a single leg squat. So be really adaptable to what you're prescribing to your patients.
And I think one of the important things to say as well, and a lot of the questions we get asked in the forums and things is, well, what exercises should we be doing and how long and how much? And the thing to say really is that every patient that we see or individual with knee pain that we see is different, and we need to be able to adapt. There is no one answer for knee pain. There's no one exercise, there's no set of exercises, and there's no specific time. So we need to be really adaptable in our practice. And I guess that's where our clinical reasoning comes in. So we need to have those skills as well.
Yeah, exactly. And look, I teach courses on this, practical courses for physios. And one of the things that I always teach is I never teach a recipe that this is how you treat patellofemoral pain or an ACL. But these are the principles you need to do. So we need to work on this hip muscle function and core muscle function and quad muscle function. That's the principle. This is the principle of progression about resistance training and aerobic. Put them together, work out where the patient sits on that spectrum, and then you gradually increase them. And actually, once you do it a few times, it becomes quite simple. But if you're used to trying to use a protocol or a recipe, then to get your head around doing that can be quite difficult. And I know when I was taught as undergrad, that's how I was taught to practice. But in reality, it doesn't always work that way. In fact, it's not optimal to work that way. And I think in terms of where to start with exercise, that's a really good question, because it's not just about how much load and I guess trying to work out the load management, but also some other principles around that is we have some patients who are just really, really irritable and they don't always tolerate much exercise to their knee at all. And often we need to settle down those knee symptoms, part of the load management side of things, which is the first point we made. But that doesn't mean they can't do exercise rehab. If we look at the patellofemoral literature, for example, what we see is some limited evidence that if you do hip-based exercise, hip and proximal-based exercise, that's more effective in the short term than doing knee or quadriceps-based exercise. So I find that really interesting because there's deficits in both of those muscle groups. So we talk about quadriceps and we talk about gluteal muscles. There's certainly weakness deficits and neuromotor deficits and various things. But if you're going to choose one of the two, you would choose to target the hip or proximal if you're going to take a broad mean population approach. And I think the important part of that is if by doing hip exercises that maybe don't load the knee, you can address some of their muscle function deficits. So you can address their strength, you can address their neuromotor control, whatever it might be, without putting any irritation into the knee. So I think in the early stages, if someone is really irritable, I think we need to do exercise, that's important, but we probably just need to think above and below the knee joint. So a lot of patients who I have in my clinic that are irritable, they'll go home, they'll have no quadriceps exercises. They won't do any quadriceps exercises, maybe for the first month or 6 weeks in some cases if they're really irritable. And they'll do a lot of hip exercises, they'll do a lot of calf exercises, and they make really good improvements from doing that. And then when they've got a bit more load tolerance, because we've settled down their loading and they're stronger with their hip, we can start to then load our quadriceps and do a few more things. So I think if you've got someone irritable, just think about above and below the joint. And the other thing that we know about exercise is it's not just therapeutic exercise for strength and to treat that joint, but exercise also has a natural endorphin release. So to have someone who's had knee pain, has kinesiophobia and is really scared of moving, they're not getting any exercise because they won't go out and do things. So even thinking and talking to them about, well, what doesn't hurt your knee? Can you go cycling? Is that pain-free? Yeah, I don't like cycling. No, but if you just try a little bit of it, you might actually start to enjoy it because you can't run at the moment because that's not great for your knee. We want to get you back to running, but maybe you try cycling. Or maybe you try doing a boxing bag or an arm ergometer or something like that just to get your heart rate up and get things moving and give that endorphin release. And I think that can be really helpful for people. And I think, so that's point around, I guess, specifics of exercise prescription. But the other most important thing around all of this is be patient. Make sure your patient is patient. That's really important.
They do expect to be better really quickly, don't they, patients?
Yeah, they do. And I think gains from exercise take time. We know that. It takes time and it takes investment of time. So we need to make sure our prescription principles and our reasoning around that are optimal so that patients aren't wasting their time, because obviously they're not going to be happy if they're doing that. They're going to go somewhere else or they're going to become more chronic. But then we also need to educate patients that, okay, this is the pathway and these are some short-term goals that we're going to aim for. And if we might not see great gains in your pain, but if we can see some improvements in strength in these areas in the first few weeks, then that's a good sign. And then hopefully by the time we get to 6 or 8 weeks that we start to see some really good changes in your symptoms. And you know what? If we want to look at physiological adaptations to your muscle, we know that's going to take at least 12 weeks before we're going to see actual muscle architecture changes in most cases. And that's in people who don't have pain. In people who do have pain, we've got pain inhibition and it potentially takes longer. So if we've got someone with chronic knee pain, to get physiological adaptations from the exercise we do, it may take 6 months, 12 months. And what I usually do is have a bit of a rule around it that if you've had pain for 6 months, you're probably looking at 6 months of rehab to get to your optimal level. And that's not to say that 1 or 2 months down the track there's not improvements, but to get to optimally where you're going to get to, 6 months of pain is going to take you at least 6 months of rehab. If you had 10 years of pain, I won't usually tell them 10 years because that scares them off. But I'll usually say, look, you should get some really big improvements in the first 3 months to 6 months because that's when we see physiological changes. But you'll continue to improve for at least 12 or 18 months. And that's what I usually sort of phrase to them. And getting that education across in the very first session is hugely important. And really important point about education is don't just tell them. If you want them to remember something, write it down. Patients remember about 10 to 20% of what we tell them, and there's good research around that. And they're not going to remember the stuff that they don't want to know. So if you tell them that their rehab is going to take 12 months and they don't want to hear that, they're not going to remember that. They're going to remember, oh yeah, the physio gave me these 3 exercises. They're going to fix my hip and my quads, and that's going to get my knee better. and they'll forget that you told them 12 months, and they'll think a month later they should be better. So I think making sure that they're really understanding about being patient is hugely important. Yeah. And I think if we talk about exercise a little bit further around being patient, we also need to have the skills and knowledge to progress that patient to their goals and their functional goals. So one of the things we learn in the early stages of our learning as a physio is specificity of what we do. And specificity can be neuromotor control, strength, mobility, but specificity is also thinking about what task that individual does. So if we want them to have better hip control for running, then we're not going to get better hip control from just doing gluteal exercises, for example. We need to actually teach them how to have better control when they run. If they're a golfer and they wanted to improve their golf swing, we wouldn't just send them into the gym to do strength exercises on their arms and hope that's going to make them have a better golf technique. For some reason, we have this different approach to the lower limb sometimes, in that we just do exercises in the hope that it will change the way we move. But we need to focus on those specific things. And that running is an example to control the hip, but maybe it's someone who plays lawn bowls or someone who plays squash, and we might need to teach them how to control their hips and their knees and things like that, so that they take a bit of load away from their knee and they're using their core and they're using their hip to control it. And we might start off, maybe if it's squash, for example, we might start off not by playing a squash stroke, but maybe by doing some lunges. And then we might progress that to doing some lunges with some upper body rotation, and then we bring in a racket and we slowly progress it. If we've got someone who isn't just running but doing change of direction sport, we teach them to control things better when they run in the straight line, and then we teach them to control things when they walk and change direction, jog and change direction, run faster, and then sprint, and then we bring a ball in. So it's just that gradual adaptation, and that's probably comes back to that very first principle I talked about, too much too soon. So we need to gradually adapt people to what they need to tolerate. And we can teach them to move better. But it's really hard to do that if you don't get the rest of it right first in the first 3 months or 6 months or whatever you need to do. If you don't feel you've got the skills to help a certain athlete or a certain person get back to the functional tasks that they want to do, maybe they're a cyclist and you think bike fit might help them, then get some insight from an expert who does that. If it's a runner, maybe you need to have someone who has some really good knowledge on running biomechanics. Or if it's kicking a football, maybe you can work with a strength and conditioning coach or exercise scientists have good intimate knowledge of that. So thinking about those things is really important. We should hopefully all know how to do things like stairs and walking and the majority of things that people have pain with, but there might be some way you bring in an expert in a particular area to help you with that side of things, and that's fine. Working together is a really good thing. So that's probably, I guess, the key points around exercise without having to talk to you for hours and hours on end. But I guess there's probably a couple other really important points to make. And that is, if we think about the whole concept about getting people better and getting them in less pain so they can do more exercise and load tolerance, one of the things that I think we need to make sure as a physiotherapy profession that we don't do is discard things like manual therapy and taping and adjuncts to help with some of these things. I think what we need to do is think really hard about why we're using them and the principles about why we're using them. So we know that in the long term, things like manual therapy are going to make very little difference to the patient's pain and function. But in the short term, now whether it's placebo or whether it's actually doing something physiological, it probably doesn't matter that much. I always talk about patellofemoral taping and the fact that that's really effective, but if you put a bit of tape on your forehead and it helps their pain and they can do more exercise, that's a good thing. Yeah. That's great. I don't mind. The key thing is finding tools and ways in which we can optimize someone's load capacity so they can do more exercise and they can get back to things faster. So when we think about these things, it's not about not doing them because they're not evidence-based, so to speak, but where will they fit into the patient's progress in terms of progression and getting them better faster? And then back to the education, we'll keep going through this as a theme, education, is educate the patient. Why are you doing it? Well, I'm taping your knee, not as a crutch, but I'm taping your knee so that you've got less pain when you walk on the stairs tomorrow at work. So you're more likely to take the stairs, which means you're more likely to get loading through your quadriceps and your gluteal muscles. And that means you're going to stop that vicious cycle of deloading and muscle atrophy. In fact, we're going to flip it on its head. Now you're going to be able to do more exercise and you actually start to get muscle gains as a result of this. So I think it's just educating the patients about why we're doing it. And I think in terms of dedicating time, then it's not the priority. So the priority is getting them on the right track with exercise rehab. So don't spend 20 minutes of your 25-minute consultation doing manual therapy and then just chuck exercise on at the end. Maybe you spend 5 minutes of manual therapy and then spend 20 minutes teaching the exercise. So it's still prioritizing it, but not throwing it out the window. Prioritizing exercise, but not throwing manual therapy and adjuncts out the window. I think that's really, really important. That's 9 points. We're doing well. And then the final point to make for everyone is I think patients need to really have a good understanding around the evidence behind different treatment options that they have. And I think this is a really big passion of mine, and that's around communication. So you mentioned communication and education, and our role as a physio is hugely important behind this, because they're going to talk to someone who's going to tell them, I had this PRP injection and my knee got better, or my uncle's uncle had a knee arthroscopy and it got better, or maybe it's not PRP, maybe it's cortisone injections, or maybe it's some new footwear or some new knee brace or whatever it might be. And a lot of these things, they're not evidence-based. We know that exercise is evidence-based, and I think that's a really important thing. When we look at it, we see reasonable effect sizes that exercise will improve someone's pain and function, and much greater than things like surgery, which sounds a lot more sexy. So surgery, when we equate it to the effect sizes and how effective it is, it actually comes out about the same as paracetamol when we look at an arthroscopy compared to placebo interventions. And I know that will actually come as a surprise to many on this course based on the survey that I sent out. But across around 10 randomized controlled trials, and this is in meniscus patients and in patients with osteoarthritis, so this is younger and older, when you compare physio and surgery compared to physio alone, or we compare surgery to a placebo surgery, so placebo surgery where we just cut the skin and stitch it back up. So you go under anesthetic, you go through the whole process, but you don't actually have surgery. Then actually there's no difference in outcomes. In fact, placebo, both are effective. So it's not that surgery is not effective, but a placebo surgery is just as effective. So both will improve patient outcomes by about 30%. We can get better gains than that in exercise, and probably more sustainable. And I think that's what's really important. And I guess on the point about the surveys, even when we look at things like an ACL reconstruction, which it's just commonly believed that you need to have an ACL reconstruction if you want to get back to sport. You've done your ACL. I think here in Australia, 90% of people who have an ACL injury will have it reconstructed. When you look at the evidence, and there's not lots of evidence, but the study that looks at quite active young population shows that actually the return to sport outcomes in a group who has surgery in the early stage versus a group who doesn't have surgery in the early stage and actually do some rehabilitation, the return to sport is about the same. There's very little difference between the two groups. So you don't necessarily need to have surgery in order to do things. But it sounds good, doesn't it? It sounds sexy. It's a quick fix. And it's much easier than exercise in terms of time. So I think it's really important that patients understand what is the evidence for each of these different treatment options so they can make a really informed decision around what they want to do. Now, that doesn't mean that surgery isn't sometimes necessary. It also doesn't mean that some patients won't still choose surgery after having that information, but we need to make sure they have those informed choices. And I think one of the job of us as researchers is to try and get that information out there, because it clearly isn't out there, certainly amongst a lot of physios, but definitely amongst the general public. I think that's really important.
Yeah. And one of the one of the ways to get it out there is for us to make ourselves knowledgeable, isn't it? Like you're saying, so that we can share the knowledge. So listening to you talk about these things is really useful, so that we have the knowledge, so that we can then share that forwards, which is exactly what you're saying for your last point there.
Yeah. Exactly. And one of the things that I'm putting together more and more, and can watch this space through the La Trobe blog site, which I'm sure we can put a link up, is a lot of patient education resources. So it'll educate us as physios, to people who want to improve their knowledge, but it's at a patient level, so that actually what you can do with that information or those information resources is you can actually give them to your patients and go, here you go, this is a nice little summary about what the research evidence tells us. And I think that saves us more time in the clinic, that we can send a patient home with some really good online resources, and we can spend more time on the exercise rehab and doing things like that. I know I spend an hour with my new knee patients. An hour goes pretty fast for me. So I spend a lot of time. I probably sit there and I probably spend 20 minutes on education with them, just around all the stuff that we've just talked about. I probably spend 20 minutes on exercise prescription. And I probably spend 20 minutes on doing their subjective and objective. And that's a pretty quick subjective and objective for me. So that's an hour gone. But I want to give them more education, and I want that education to stick And yeah, so we just need to use resources out there. So hopefully we'll see more and more, and we'll put a couple up via the course notes so that people can get onto them and use them.
That's really useful, Christian. I think all that you've said has actually totally summarized everything that we have covered in the course, which has been really, really good. I think it's a really nice to talk to you at the end of this to summarize everything, to bring everything together in those nice 10 points that you've made. I think there's definitely key messages there that about education, load management again, and as well, it's interesting, it's really good that you talked about the exercise prescription, because we do get asked a lot of questions about how many and which exercise should I do, and it's really good to highlight that it's your clinical reasoning that will allow you to prescribe the right exercises for the individuals that you work with. So it's good to hear you talk about that as well. So we will be able to put links to La Trobe and the work that you do and the resources that you share so that people can use them as well. And yeah, it's been really good to talk to you. Is there anything else any other messages that you have for people doing this course at the end of the course?
I think if you already know a lot about knees and doing like treating people with knee pain, you probably learn a little bit from the course, and I think probably just keeping your mind open that you'll continue to learn more. I guess if you're starting from a less experienced level, then hopefully you've learned a lot, and I think you'll probably continue to learn more. And I think online resources are really, really important, and I think go away and make sure you maybe set up little support groups to talk to each other about what you've learned. I think that's really important. And you just mentioned about people don't always know where to start, and it's about clinical reasoning. And some of you will listen to this and still sit there and go, oh, I still don't feel confident to do that. So I think the key thing is calling on your peers to try and help you with that side of things, and just being really clear about what your reasoning is and understanding it. And the most important way to do that is describe to patients. But what's great, I think, just keep engaging with you guys as Physiopedia and other resources out there, because there's plenty of stuff out there that we can keep learning. I think it's going to get better and better. So your learning doesn't stop here. That's probably in one sentence.
Yeah, that's a really good way to summarize, actually. Christian, it's been great to talk to you again today. Thank you very much for being a part of this course. Thank you for chatting to us. It's been great to share your knowledge.
My pleasure. Thanks for involving me.